I think we're just coming back to the realization that our body is a system, not just individual processes breaking that we need to fix with one drug.
All right. Well, it's a real pleasure to have Dr. Darshan Shah on the show today. Welcome.
Thank you, Zora. It's so good to see you again.
I'm so glad we finally got you on. There was a little back and forth, and
Mhm.
it gave me more time to also keep following your podcast, which is fabulous. And I'm absolutely loving it and sort of binge listening to everything. And it's excellent. It's called Extend Podcast,
Yes.
right?
Mhm.
Is it the Extend or Extend? Just so I get this right.
Just extend podcast. Yes. I think
Extend
your
Podcast.
episode's coming out soon too with me. Hopefully
Yes.
they're going to get that out there in the next few weeks. So yeah, thank you for listening.
Yeah, no, you've got some amazing guests. Honestly, I highly recommend people to go listen to it. And what I learned is when I was first learning about you in your first episodes, I didn't know that you were one of the youngest doctors in the US and you got a medical degree at the age of 21. So explain this. Like, how did you even do this?
Yeah, it's just a lot of, I guess, luck combined with hard work. It's always a combination of those two things. And I was able to skip second grade just because I was doing well back then in school. And then through college, I mean, through high school, sorry, we moved around a lot and I did a lot of like classes over the summer at colleges for fun kind of a thing. I took like a chemistry class and you know how it is when you get AP classes, you also get a lot of extra credits. And so I was able to graduate high school a year early. And then I was very lucky to be admitted into a medical school that followed the English pattern of medical education, which was to go to med school right after high school. And you go 6 years straight with no breaks, no summer breaks, nothing like that. And so I was able to cut down a traditional 8 year training program into 6 years. I went to college when I was 15. I graduated 6 years later at 21, and I was in the operating room at my right before my 22nd birthday in my surgical residencies, where I started my medical career as doing surgery.
It's incredible. It's an amazing story. So you've got loads more experience than some people probably the same age as you because you just got that head start. And I was just so curious like how that even works. So well done. And
Thank you.
yeah, I'm totally going off topic, but I'm just curious. What was it like at your age to be doing your first surgeries because you've done quite, I mean, you were going into plastic surgery, trauma surgery, breast cancer surgery. I'm not sure which ones you started with, but what was that like as a young man to be on the operating table?
Yeah, it was, first of all, it was a privilege to be there. I look at doing surgery as kind of like being an astronaut. Like you get to do something that most people on the planet will never get to do. And it's a privilege. And so I was very excited to be there. It was the only thing in medicine I could do back then because I was just not inspired by the rest of medicine, which was just really treating sick people with medications. And so I felt with surgery, I could actually make a difference and I could see the results immediately. And it was exciting. And I think the most complicated branch of all of in healthcare, because not only do you need to know the medical aspect, how to diagnose, how to treat, how what pharmaceuticals do what, but you also need to know how to operate on people, which is a more physical skill. So I had a lot of, I would say, just awe being there. And also, I was humbled that I was there at such a young age. But being young didn't really faze me because I'd already lived through medical school for 6 years, which was grueling. So I had already a lot of experience working my butt off. And surgical residency definitely is a place where you work your butt off. And
Yeah.
I was able to just slide right into it and came out of it after another 6 years of training in surgery. So I did general surgery and then reconstructive surgery training as well. And so that included trauma, that included cancer reconstruction. And yeah, I was able to really spend another 6 years learning how to do surgery.
Incredible. And then you shifted into this world in functional medicine, and you've got all these amazing regenerative medicine clinics. I'm not sure how you'd probably define it yourself, but it's pretty amazing how far you've come as well because you've gone from this traditional model into next level health pretty much. And so with all your experience in these surgeries, have you learned any differences between men and women and their health and perhaps maybe their outcomes after surgeries or just anything in general?
I mean, absolutely. I mean, first of all, the reason people go to the operating room, whether you're a male or a female, can be very different. So we did a lot of cancer surgery. Unfortunately, most cancer happens in women. You have breast cancer, you have endometrial cancer, a lot of hormonally regulated cancers that occur in women over men. So you find yourself operating more on women than men, actually, when you're doing cancer reconstruction and cancer surgery, actually. And that's one difference, I would say. I would also say that the biology of a man and a woman is very different. And so when you're treating people after surgery, before surgery, you really have to adjust your thought processes around the biology of where they are in their lifespan, their hormonal regulation, their immune function, all of it.
Oh, like, well, it's certainly serves, I'm sure, with everything else beyond surgery and all the things that you're doing now. So kudos to you. And as I was also learning more about you, I found this really comprehensive wellness wheel, and I thought it was fascinating. And it's just such a great tool. And I'd love for you to share what it is and why it's relevant to a woman in menopause.
Yeah, I created the wellness wheel was because when I switched from doing surgery to what I call now health optimization and longevity medicine, I found that even in my own life, that it was very difficult to put all the pieces together. There's so many pieces to health, wellness, longevity, and for women specifically, getting through the stages of life as well. And so I created the wellness wheel to really bring it together into a unified model that I could explain to my patients using a graphic. And so the way I look at all of health and wellness, and this is because I have experience in all the different branches. I came from traditional medicine. I trained in functional medicine. I also am a nutritionist and a personal trainer certifications as well. So I have all this varied knowledge. And I think people get lost listening to people that have experience in one part of medicine or health and not all of it together. And so what the wellness wheel does is it separates a person's health and wellness journey into 12 different categories, and those are divided into 4 groups. And when we see a patient at Next Health, we always start with the basics of health and wellness that we all know: nutrition and metabolic health, sleep and exercise. In the Western medical system, this is called lifestyle medicine. We call it lifestyle medicine because it almost makes it seem like, oh, this is just how you should be living your lifestyle. But in reality, this is the rocks and the fundamentals that everyone needs to consider. So we always start there. Then we move on to preventative medicine. So this is where primary care is supposed to help people prevent disease. The problem is we just do way too much too late. And so what we really try to do is we bring forward 20 to 30 years, all the technology that's been locked up in the Western medicine system to prevent disease rather than treat it once it happens. What I'm talking about here is heart health, cardiovascular disease. More women suffer from cardiovascular disease than men. It's just most people don't know this fact. Secondly is prevention of Alzheimer's. Again, more women suffer than men. And cancer as well, so immune system health. So we address all of those with our preventative program that is extremely proactive in preventing disease. I always say that cancer's biggest enemy is being diagnosed as stage 1 because you can still do something about it. The same is true with cardiovascular disease, cognitive impairment, all of it. So we really want to be much more proactive than we traditionally have been. Secondly, what I would say, so after that, what I would say is we move on to functional medicine. Now, this is also kind of a newer field of medicine. I'm saying that in quotes, because in functional medicine, which was pretty much developed by Jeffrey Bland and Mark Hyman and a few others about 15 years ago, this was not taught to any physicians that are out there in the wild right now, because this was a new thought process that was created that was separate from typical medical school education. And functional medicine really embodies the knowledge base around hormones, around toxins, around gut health, around emotional health, and how this all fits together in a systems biology approach. And I was really lucky to have learned all this when I was going through my own health struggles, and this made a huge difference in my life as well. And this is where women really need to focus their energy as well, because the changes in hormones has a huge impact in the biology of a female and all the chronic disease risk factors as well. And then lastly, what I would say over the last 5 or 6 years, we have seen an acceleration in knowledge around longevity medicine. And what I really mean here is all of what a lot of people hear about biohacking. I hate the term biohacking because you're not hacking anything. You're using new science to really accelerate your health and wellness journey. And what I'm speaking about there are technologies such as peptide therapy, hot cold contrast therapy, mitochondrial health therapies, plasma exchange, stem cells, regenerative therapies. I put all that in the bucket of longevity medicine right now, but really this is where things are going. And so when we take people through these 12 points in these 4 different categories, we can really affect their overall longevity, their avoidance of chronic disease. But the best thing about all of this is people start feeling incredible again. You feel like you did back when you were in your 20s, when you were unbreakable. And this is where we want to bring people, is to a sense of wellness in your own skin, and also a sense where you can just enjoy life and you feel like you're going to do that basically forever. And that's the model.
It's very comprehensive, and it actually takes such a multi-pronged approach. I think most people in this space of ours do talk a lot about the nutrition and the exercise piece, sleep, stress. And then some of us talk about community and purpose in life, et cetera, as being the sort of foundation. You kind of go beyond that. I mean, you go like another layer and just kind of a deep dive into some of those things, which I think are really important. And I encourage people to go into your website and take a look at the wellness wheel and see what parts are missing and what needs to be improved. But it's a great tool, I imagine you're using as well for your clients to actually visualize and then show as you're working with them, okay, we're going to cover these. We got these 2 left and we're going to work on that too. And that must be a process. I'm sure it doesn't happen in several weeks. It's the average client that you see. How long does it take for them to actually get most of this wellness wheel covered, or do they never ever get it?
Yeah, no, it's usually we could take people through the entire process in about 6 to 8 months. And so what we do is we always start anybody, like if you were to walk into one of our clinics, we would start with a comprehensive biomarker evaluation. So we're taking your blood test. We measure over 500 or 600 blood tests. We do a genetic swab on you. We also measure all your toxin levels with a urine toxin test. And then we also do biometric analysis, your skeletal muscle mass, your fat mass. We do certain tests of like your grip strength. We test your balance, and we collect all this data. And that points us in the right direction of where do we need to focus our energy at this moment in time. And then once we get all that data together, we can create a plan that usually within about 6 to 8 months, we can completely reverse the course of your health and get you feeling really good again. So our programs are usually like a year-long membership, but we can make major changes in the first 6 to 8 months for sure.
That's okay. Good. I like to see sort of general number what you're saying, but you've got enough clinics, enough patients now you can determine that. And one question that yesterday somebody interviewed me on a podcast, and I would like to hear how you would answer this, because it was about biohacking menopause and wanted to know a bit more about that biohacking world. And we all sort of have our own little definitions for it. But she says, in general, people look at biohacking as inaccessible and unaffordable for most people. And so she wanted to hear my thoughts on that, if I could refute that, and I'd love to know how you would answer that question.
Yeah, that's a great question. I think most people look at biohacking as something inaccessible is because they see people that are biohacking that are using expensive technology. And really, the expensive technology is just the icing on the cake. Like you've done everything else and now you want to spend a few bucks on something expensive. None of that really contributes to the majority of the difference that you can make in your health without using those technologies. So I'm always talking about the Pareto principle. The Pareto principle is where can you get 80% of the result by focusing 20% of your resources, right? And that really comes in the form of the things that you talk about. It's exercise and movement and getting that right. It is your nutritional patterns, your metabolic health, your sleep patterns, and then your hormones. Just what percent of the population right now has not had their hormones measured? It's for men and women. It's really criminal how we don't even look at hormones on women, even when they're going through menopause, right? Most primary care do not measure a hormone panel unless someone is complaining and really, really begging for it. And a lot of times women are just given estrogen patches to use without even measuring the levels. And so I don't consider hormone measurements a biohack, but some people do. And it's super cheap. It should be free to get your hormones measured if you have health insurance. You just got to ask for it. And if your doctor doesn't want to order them on you, just find yourself a new doctor that will. I think that's like step one in biohacking, and that's fully accessible. And that makes a massive difference knowing what your hormone levels are, right? And that makes much more difference than buying yourself a $150,000 hyperbaric oxygen chamber in your home.
Yeah, the hormones are such a big piece, and I think we're all confused. And plenty of women I know never even track their period, and when we are going through our own adolescence until adulthood. So I think it's a thing that we're all learning more about. And I do interview a lot of doctors who say, look, there's no need to test women in the perimenopause phase. We go by symptoms. We give her what she needs. Some doctors would say, oh, we'll test her afterwards. She's on the hormone therapy. But I kind of get why they'd say that, because the hormonal fluctuations are so erratic during the perimenopause phase. But at the same time, if it were me, I still test, and I like to know, and I understand it can be fluctuating. But how would you empower a woman who has a doctor like that and says, oh, it's not necessary?
I think that is absolutely ridiculous when I hear that, because it's like, let's just keep driving our car until we run out of gas and then we'll deal with it then. Like, you want to know how much gas you have left in your tank at all times. It makes zero sense, especially because it's zero risk to test your hormones. It's a simple blood test, and it's almost zero expense, right? I mean, in reality now, testing hormones should cost no more than $10. And so why not get the data? Excuse me, why not get the data, right? I think it's so important to have the data, because your hormone, you're right, estrogen is fluctuating a lot. But what about progesterone? What about testosterone? We need to know where you stand on those levels, and then we need to institute treatments and then recheck the levels to see if your symptoms correlate with the hormone deficiency. Because if they don't, we have to go looking elsewhere for what are the symptoms. And so I think it's flying blind when we say we don't need to test hormones until after perimenopause is over.
Do you think some doctors I've interviewed, they would say, well, what we do is we test the hormones, whether it's estrogen, progesterone, testosterone, and their subparts, but we want to know when she took her hormones, if she's on hormone therapy, when was the last dosage, and then they're asking a lot of questions so that they understand sort of the rise and the fall of the hormones, so that they can interpret it in context rather than come any day and let's see. So some doctors want you to come on a certain day of your cycle if you still are cycling. I'm wondering if some doctors just don't even want to go there because they don't understand how to put things into context and direct their patients that way.
Absolutely. I mean, like, managing someone's hormones is a really specialized branch of medicine that not all doctors get trained in. Even your OBGYN, a lot of them have not been fully trained in it, and a lot of them have not done it for years and years. So I think you have to undergo specialized training as a physician to manage hormones. And I think it would be a really great idea if a physician was just say, like, look, I don't normally treat hormones. And so why don't you go to someone who does? And there's many, and not just doctors, there's many nurse practitioners and physician's assistants that are incredible at hormone replacement therapy and managing hormones. And what I would say is, if the doctor doesn't really seem like this is something they do on a day-to-day basis, it might be good to find someone who specializes in that. Functional medicine physicians and practitioners are usually really good at hormone therapy because it's one of the core things that we do. But the other thing I would mention too is coming in at a specific time for hormone tests and making sure you understand the history. That's super important. And if the doctor or the practitioner is not asking those questions, that should be kind of a flag to you that maybe you should find someone that is asking those questions. I very much like the Dutch test, which is the metabolites of the hormones that we collect your urine samples as well. And so practitioners that use the Dutch test, that gives you another level of confidence that they really understand all of the ins and outs of hormone therapy and hormones in general.
I'm also a fan of those metabolites. And again, I think just like you said, if you don't have the training and it's foreign to you, I think it's important that a doctor would say, hey, look, I'm not versed in this, and perhaps I can refer you to somebody. And it reminds me of a reel I did really well, about the 5 phrases you can tell your doctor or ask your doctor to take your menopause concern seriously. And as I have you in front of me, maybe I like to hear what your thoughts, and then maybe come up with something better or say that's perfect. I don't know, because I think some of the questions, some people would say, well, it's being, I don't want to say aggressive, but it's something that we're not maybe used to advocating so much for ourselves. So one of the questions I remember was that it was just basically saying, I understand there's some doctors who are not comfortable treating a woman through menopause. Is that you? And if so, can you refer me to somebody? Is that, what do you feel about that if somebody told you that? Not that you're definitely not the person, but
Absolutely. I mean, having phrases like that, I think are considered more commonplace now, right? And so everyone needs to advocate for themselves and their own health. And you should not feel embarrassed or hesitant to ask your doctor, how comfortable are you treating hormone replacement therapy? Is that something you normally do for many patients? And if not, who can you refer me to that is comfortable with this? Because I want to go to someone that really specializes in it. And I think if the doctor or practitioner gets upset at that question, it usually is a red flag that this is a person that's just kind of churning through a lot of patients. And you really want to make sure that you understand like what you have a lot of choice, right? In your physician, you're not stuck with one physician. You should have the amount of self-respect for yourself to go find someone that will do a better job, right? And I always use a car analogy. Like if you go to get your car fixed and they just tell you, look, don't worry about it, I'm going to fix it, don't ask any questions, and that's a red flag. You would not probably keep going back to that same place. And so it's the same kind of thing. I always use a car analogy because I feel that humans put a lot more energy, effort into their cars than they do their own body, unfortunately. And we need to flip that mindset a little bit.
Yeah, I remember this quote I found recently: invest in your body because it'll be around a lot longer than that expensive handbag. And
Mhm.
I thought, well, yeah, it's true.
So
It's
true.
absolutely true. So then I would like to know then, if somebody comes to you who's perimenopausal, let's say, or postmenopausal in this transition phase, and she needs some help and she walks into your clinic and she wants to see you, maybe you have other doctors who are there. What is your process of treatment? How would you approach that woman and what would you offer her?
Yeah. So we don't treat hormones in isolation. We do full testing. So we want to know where is their metabolic health as, where is their cardiac health and their cholesterol levels as well. How are they handling blood sugar? How are they handling inflammation? All of these things go hand in hand. Okay. And so we're doing a comprehensive analysis of all of the biomarkers. And then normally for almost every woman, we're not just treating hormones in isolation. We're also treating their metabolic health. We're also treating their inflammation, their gut health. It's a combination of treatments that we're offering the patient, including hormone health. And so normally we'll measure the hormones. Sometimes we'll have people come back for a second set of measurements. So we get it during a different phase of the cycle. And sometimes we also have them do the Dutch test as well, not always. And then we start them on a regimen, usually is some combination of estrogen, progesterone, and testosterone. Yep.
Interesting. It's actually amazing to be able to walk into a clinic, and most of the women have symptoms, they're like, I just want to feel better. I just want to get rid of these symptoms. Maybe they've heard about hormone therapy. Just give it to me. I'll start with whatever. But in fact, I always say myself, you can't out hormone a bad diet and lifestyle because there's a lot of other levers there. And are you detoxing well? Because here you are putting more hormones in. And so it's like, we need to make sure the whole system is running. But it's very rare to find a doctor who will look at that whole picture as to a menopausal woman. It's kind of like, let's help her now. And I get it. And it's the way that we were trained and that's the way you do it. So I'm impressed. That's a great approach, but it's a long process. So when a woman who is coming in with the symptoms and wants help, would you do all of those 500 blood biomarkers or things that you talked about, or will you do certain
Yeah.
these things at a different time?
No, we have a very set baseline panel, we call it, and we get it on everybody that comes in through our door, man or woman, because we really believe that we can't be treating individual aspects of someone's biology in isolation. That's like the wellness wheel is a wheel. I always say all these spokes interconnect, and what
Mhm.
you do with your hormones is going to affect your gut health, and what you do with your gut health is going to affect your hormones. And so there's no separating the two.
Yeah.
Yeah.
I just came back from the European Menopause and Andropause Society Congress that was in Valencia, and most of the attendants were doctors. And I could see the confusion among doctors because of the guidelines, which were not very clear in many ways, because a lot of the presentations, the research shows what happens to a woman's brain or her heart as she is losing her hormones. It's clear what happens to her bones and osteoporosis. And so some of the doctors even had to come up and say, look, your guidelines say the woman is asymptomatic, probably the only like 4 or 5 symptoms that she knows of, when there's some people say 103. The question is, she comes into me asymptomatic, and how do I treat a woman according to your guidelines if she is asymptomatic but is worried about her bone health or her future brain? How would you respond to that?
I think that there's a really poor conception in medicine right now that you wait for symptoms before you do anything. We know for every disease process, whether it be Alzheimer's, cancer, osteoporosis, cardiovascular disease, the symptoms occur when you've been living with the disease for 20 to 30 years, and now your body's lost all resilience to the effects of that disease, and you're finally exhibiting symptoms. So my answer to that is you can never wait for symptoms to develop. No one should wait for symptoms to develop ever for any disease process. That's why we're in this state of chronic disease epidemic that we're in right now, and we're spending $4 trillion a year on healthcare, is because we've been waiting way too long. 30 years too long for symptoms to develop. I really believe that the treatment should start in perimenopause, and whatever the symptoms are that the person is feeling, we know why they're occurring. We know is because of the hormone dysregulation. And so we don't need more than one symptom to start treating them. I think it's why wait until, you have all of the symptoms of menopause, and then now you finally start hormone replacement therapy. We know the research is clear that the sooner you start estrogen therapy, the longer you delay any cognitive impairment diagnosis, any cardiovascular disease diagnosis, potentially forever. And so I think it's really important to start sooner rather than later.
I agree. And then there's the silent killers where we don't feel our heart and our arteries getting clogged. We don't feel our bones becoming brittle.
Exactly.
And Alzheimer's, the symptoms don't appear until much later in life, but actually Alzheimer's can start 20 years or something more before the diagnosis. So why then it's too late? And I just can't understand. And I thought this doctor was, it was a very relevant question. And
Yeah.
so then that comes with testing, because you don't feel these things, or you may not associate joint pain or brain fog with menopause or hormones. You may think, oh, I'm going to get Alzheimer's, and maybe it is the first signs of dementia, but maybe it's your hormones. But it's these things that you got to see a good doctor to be able to test you, measure you, and assess you, and then make a great proposition of how to solve these problems. And then, of course, through the life course, keep testing and see the evolution of your brain health or of your heart health or whatever it may be. But I think your point of, you mentioned women have die more of cardiovascular disease than men. We have more incidences of Alzheimer's. And so the first thing that I think of, well, duh, well, she's lost her hormones, but it's probably much greater than that. It can't be just the hormones. Or do you think, no, that's the biggest lever that's driving these diseases of aging?
It's definitely a combination of factors, but the main disease is aging, right? And so if you look at aging as a disease, that is the number one risk factor for all of these other chronic illnesses, right? And so aging, if you want to get more specific about it, there's 3 or 4 things that happen during aging. One is loss of hormones, right? So men go through andropause, women go through menopause, and we lose our hormones. The second thing that happens as part of aging is metabolic health issues, right? And so now we become more and more insulin resistant faster and faster. The third thing that happens during aging is loss of skeletal muscle mass. Skeletal muscle mass is directly what protects your bone mass. When you lose skeletal muscle mass, there's a one-to-one relationship on also losing bone mass. And so this also occurs by itself with aging, okay? And the next thing that happens is immunosenescence. Immunosenescence means basically your immune system does not function as well as it used to, and so you get more inflammation as well. And also immunosenescence is what leads to cancer as well. So all of these are factors that automatically occur with aging if you're not doing something to mitigate those different factors. How do you mitigate those different factors? Well, hormones, you want to do everything you can to maintain your hormonal balance. Part of that's going to include hormone replacement therapy. Skeletal muscle loss, you have to make sure you're managing protein intake, you are lifting heavy things, and you're also supplementing if you need to with vitamin D3, K2, creatine, et cetera, right? Metabolic health. I'm a big user of the continuous glucose monitor. This is incredible data that you can get on yourself and understand how to regulate your metabolic health. And so these are all things that we can do in concert to mitigate the effects of aging. And when you do that, you end up not having to deal with a chronic disease that occurs 20 to 30 years after the aging process has started.
Yeah. And I think, like you said, that when you talk about the metabolic health, the muscle, the bone loss, immune system going down, estrogen is protective of all these things. Not that it's the only thing, but it drives a lot of the loss. And then replacing it, again, it's not the be all end all. It's just going to support our efforts to get to the gym or start building muscle or to protect our bones. And I think it's a web. They're all connected. But speaking of andropause, male menopause, I guess, you want to describe it for the people who don't know it. The men lose testosterone. And so it's not the same way that women lose our hormones, but what men do get osteoporosis too. So is this, we always say, well, it's estrogen usually is the main hormone. When we lose that, it's driving the loss of the bones. Is it testosterone for men, or are there other levers working here?
It's testosterone for men and women, and that's because testosterone is what supports our skeletal muscle mass. And so your bone mass is supported by skeletal muscle mass, and it's your skeletal muscle is incredible at a few different things when it comes to your bone. Number one is it provides constant tension on your bones, and that tension stimulates the osteoblastic activity of the bone. So you lay down more bone. So the more you weight lift, the more you use your muscles, the more bone you're going to lay down. Also, skeletal muscle is an endocrine organ, and that means is secreting hormones. They're called myokines, and the myokines also support bone health. Thirdly, the more skeletal muscle mass you have, the more you're moving. And so the more you're moving, the more impact you're putting on your bones. And that impact on your bones also supports bone health as well. So there's direct and indirect ways that your muscle supports your bone health. And we've gone through decades of thinking, oh, well, bone health, you just need to take more calcium because bone is made out of calcium. And that doesn't work. We know taking more calcium doesn't help your bone health. It's really the skeletal muscle support that helps your bone health.
Yes. Okay. So do you think it's so if I didn't, I'm not sure if I even understand the answer for men, then osteoporosis, when they do get it, it is not only the loss of testosterone, but kind of all these things, the loss of muscle, and they're not training as well. It's a combination of things, not there's no driver like at least in these menopause conferences when they're talking about osteoporosis, just give the woman estrogen. It's all clear. We all have enough data. And they keep going to estrogen, even though you're right. It's testosterone has a lot to do with it too. But what are these conferences saying about the men?
I think that obviously women need estrogen replacement therapy if they're in menopause and they're having bone loss and all these other symptoms, right? But women as well, they need to be lifting heavy weights, they need to be managing their protein intake, et cetera. So it's not just the estrogen, it's a combination of factors. There's this condition in medicine that we call frailty, right? It's basically when you become a little old man or a little old lady and you can't move around and you're shuffling and you fall down, you break your hip like instantaneously, you end up in a hospital and then you end up dying because you can't heal this injury. And so this is a condition that a lot of us imagine the future of our life will be. We're going to become a little old man or a little old lady. That happens because of we stop moving in our 30s and 40s. We become more sedentary. We stop moving. We definitely stop lifting heavy weights. And that's kind of what leads us down this path to frailty and then to becoming unable to take care of yourself. And so it's a combination of factors. It's not just the estrogen. It's not just the hormone loss. Yes, that is a fact. That is a big role to play in it, but everything works together. And so just because you're taking estrogen doesn't mean you're going to maintain your bone health. If you're still just completely sedentary all day long. And so you have to have a combination of both the activity, the muscles and improvement, and also the strength improvement combined with hormones.
I think you need to come to Europe and speak at this conference because I think the doctors are not getting the memo that let's talk about all these things to a woman when we are giving her estrogen for her bones, for example. That's one of the reasons you can in the guidelines, but I don't think that they're talking the way you're talking. So that needs
That's
to.
very typical Western medicine. Typical Western medicine is always what's the one thing that we can give to alleviate the one symptom?
Yeah.
And that's why we are in the state that we're in right now, is because it's very hyper focused on the randomized controlled trial that shows that this one chemical affects this one end outcome. And the problem with that whole methodology, and that worked great for many, many years when you're treating infections and you're treating some disease states. Thank God we had that system that was developed by the medical school community actually after this report that came out back in the 1950s called the Flexner Report. Do you know what this is?
No, what's that?
Okay. Yeah, you'll have to look this up. I'll give you a quick summary. So back in I think in the 1940s, actually, there was a report that was commissioned by the government called the Flexner Report. Mr. Flexner was a educator, and he was sent to every medical school in the country to evaluate how do we improve our medical schools because there's very poor medical outcomes right now. And so he went to all the medical schools and he said, you have all these medical schools doing different things in different ways, and none of them are evidence-based, and half of them don't even have a laboratory where they're measuring anything. And so we need to standardize medical education. We need to be evidence-based. Every medical school needs a laboratory. We need to do research on what works in medicine and then institute therapies based on that research. And this was when infections were running rampant. We had no antibiotics and we had no ability to treat infections. And so this is what led to the medical revolution with antibiotics, right? However, what that system did was put all of medical education in this mindset that there is always one treatment for every disease process. And that's kind of where medical education is right now. We use these randomized controlled trials to try to treat chronic disease. So we're looking for what's that one drug to slow Alzheimer's disease. And the reality of the situation is it doesn't work that way. Everything's an interrelated system. We have to treat multiple aspects of our biology at the same time to get to the end result. And that's why the wellness wheel is kind of the new way of practicing medicine. It's putting all of this together under one unified treatment concept to reverse chronic disease.
How do you think the wellness wheel compares to Chinese traditional medicine or Ayurvedic medicine? Because it seems like this has been around for also thousands of years, maybe not science based back then, but it almost sounds very, very similar. So what do you think?
Yeah, ancient medicine, Ayurvedic medicine, and also Chinese medicine, they always looked at the person as a whole. They always treated multiple aspects of a human through diet, through movement, through herbs, and through plant medicine. And they did it centuries ago. And so I think we're just coming back to the realization that our body is a system, not just individual processes breaking that we need to fix with one drug.
Yeah, exactly. Okay, we've got like 2 minutes. And I have so many questions. I think I'm gonna have to have you on again because I've only gotten through a few of my questions, but we can talk about two things, either the therapeutic plasma exchange or NAD. Which one do you want to attack first or only? Because we'll have to tackle the second one in another episode.
Yeah. No, let's do a whole other episode on plasma exchange because plasma exchange is a big topic and it addresses what I love about plasma exchange. It addresses the wellness wheel because it's a one modality to affect multiple different aspects of your health through detoxification, reduction of inflammation, mitochondrial stimulation, all of it. So we'll do a whole episode if you like on plasma exchange because I think it's an incredible technology that we have. NAD is also a breakthrough technology. So we know that we have little organelles inside of each one of our cells called mitochondria. Mitochondria make ATP, which is the currency of energy for every cell in our body. Obviously, without energy, we cannot function. We cannot do any of their metabolic processes or any process that we need to do. And so one of the other aspects of aging that occur as when this happens automatically is we stop making enough NAD as a precursor to making ATP in every cell in our body, or NAD levels start declining as we age. And so NAD therapy replaces that NAD to give our mitochondria the substrate it needs to make ATP. There's different ways of getting NAD into your body through supplementation of NAD. And my favorite way is using nicotinamide riboside, which is a form of NAD precursor that is much better absorbed by the cell. So there's a company called True Niagen that makes NAD and that's makes NR,
And on.
sorry, and that I recommend to our patients. You can get that IV or orally, and we do both for our patients. IV, whenever they're in the office, I can do an IV, and everyone takes it as one of their core supplements that they take at home as well.
I interviewed Dr. Sandra Kaufman. I don't know if you know her. If not,
Yes, I've heard of her. Yes.
I gotta connect you. If you, she'd be a great guest. She took a deep dive into NAD, and she mentioned that there's NMN and NR, and they and different tissues or different cells like different. Sometimes some of them like NMN, your eyes maybe like NR, and so it was more like, oh well. So she takes both. She's like, well, I know that I need both. So have you heard of that? Is that true?
Yeah, I think some people do take both. I think there's a lot of research that still needs to be done about what's the most effective. Personally, I just take NR because I feel that I've looked at the science, I've read all the papers on NR, and I just feel that it does a great job at replacing NAD stores. The other thing, another aspect of this to really think about too is just the overall health of your mitochondria and how do we keep our mitochondria as healthy as possible. And that's where doing treatments like hot cold therapy, sauna, and cryotherapy, or cold plunge, that can really help boost your mitochondria levels as well. And there's another supplement which I really like by Timeline called urolithin A. And
Yeah.
this supplement actually has been shown to improve mitochondrial health, create new mitochondria. So you look at the substrate, which is like the coal going into the coal oven to make the fire. But also, what if you just had more coal ovens and you had brand new ones, you know? They would also make better NAD and ATP as well. And so there's different ways to improve mitochondrial health that also needs to be part of the conversation.
We need a part two because I have more questions about NAD. So I know I have to let you go. You got to run, but I would love to share with people. Go listen to the podcast. It's the Extend podcast. I'll have a link to that in the show notes. Your website is next-health.com, and I'll have links to your Instagram and your email as well, so people can get in touch with you because they want to know more about your health centers, your clinics. Is there anything else you'd like to share before I let you go?
No, thank you so much, Zora. You're such an incredible interviewer and you ask all the best questions. And this is such a fun conversation. I can't wait to do it again. And yeah, if anyone else wants more information, we talked a lot about biomarkers. I have on my website, if you go to drshah.com/biomarkers, a guide to your biomarkers. I really want to empower people to understand what are the blood tests that make a difference and what do they mean and how you can affect them. And so it's a free resource that people can get. And can't wait to get back on your podcast with you, Zora.
Excellent. Well, thank you so much for your time. Have a wonderful day. Welcome. Thank you very much for everybody else who made it to the end of this podcast. I appreciate you spending time with us, and then we will see you again, hopefully very soon.
Yes, you will. Thank you.